This is always one of the best and most wonderful panels at Health 2.0. This is the Unmentionables panel. And this is the panel where we don't do so many demos, and we really don't talk so much about health and healthcare the way that it gets talked about at every other healthcare conference. And the reason that we don't do that this way and we do something so radically different and so radically wonderful is this one wonderful woman, Alex Drane, Queen of the Unmentionables. Come on, Alex, come out. Woo!
Thank you. So I woke up last night, in the middle of the night, in a full-on sweat, panic, thinking about this, stressing about this, worrying about this. And so I'm learning from all these stress apps that I'm trying that when you wake up in the middle of the night or when you're panicking and your heart is racing, you need to reframe and think about something positive. So I'm like, oh, what's positive? What can I think about that's positive? And I thought about stuff that I love about the Unmentionables, which is obviously what we've accomplished over the last couple of years. But for me, it's also that I think the Unmentionables is like a Rorschach test here at Health 2.0. Because what people think the Unmentionables is like a window into their soul. And I can't tell you the number of times someone will come up to me and say, what's the Unmentionables? And I'll say, because I'm a mama with kids, and anytime someone asks you a question that might have to do with sex, the right thing to do is return the question. So I'll say back, well, what do you think the Unmentionables is? And sometimes people will say things that I think, oh, that's a good one, that is. And sometimes people will say things that I think, oh my goodness, you just said that out loud. That is not what the Unmentionables is, and that's not what we're going to talk about on stage. So let me ask myself the question and tell all of you that the Unmentionables is really a movement. It's a mission. For me personally, it's an absolute obsession. And it's the notion that the definition of health needs to be expanded to include life. And that when life goes bad, health goes bad. And every movement or every sort of obsession starts with a moment. And I want to tell you guys quickly the story of what that moment was for me. So I was driving to work. I was late because I had breakfast with somebody, so it was around 10 in the morning. And I noticed this man walking along the street in my town. And he was holding the hand of a little girl. And his whole body was tired. And he had that belly that just screams, you know, high blood pressure, high cholesterol, early stage diabetes, or maybe full-blown diabetes. And he just looked gray. And I thought to myself, oh my God, my company, with all the best intentions, with so much love, is going to reach out to this man today, most likely, and we're going to talk to him about taking better care of himself and getting a colon cancer screening, and he needs to take that blood pressure medication, and he should get on top of that diabetes. And he doesn't need that. What this man needs is a job. This man needs a better life. So really, the notion of the Unmentionables is here we are talking to people about stuff that we think matters a lot, while their lives can be in absolute disarray. And there's a model or a framework to describe this phenomenon that most of you are probably familiar with. It's been around since 1943. And it's called Maslow's hierarchy. And it's pretty basic. The notion is, how could I possibly be worrying about all these things up here when I don't have the basics shored up? So at ELISA, where we did all of this research, we had done well over 1 billion interactions with real people about their health. And as we were coming upon this realization, we thought, let's go look at our own data and see what our own data is saying about this notion that maybe we're missing the boat on some of these real driving factors related to health. And what we realized was that when we reach out to somebody and say, hey, you know, go see your doctor, or go take care of your diabetes, or go get a mammogram, and someone says no, and we would ask the follow-up question, why not? Very rarely would someone say, because I don't believe in it. What somebody would say is, oh, I would love to do that, but I can't prioritize that right now. My husband just lost his job. I'm caring for an aging parent. I hate my boss so much I can't breathe. And so we came up with this hypothesis that maybe the biggest diseases in the US are not just the ones that you see in front of you right there, but actually all of these life challenges, right? All of these things that wake each of us up in the middle of the night that we stress over. So what I'm going to run through really, really quickly, because we have amazing folks to come tell much more interesting stories than I could, is an Unmentionables 101 primer. So we're going to go really, really quickly. If anyone wants more data than this, I'd be happy to share it with anybody. So To validate this hypothesis, we wanted to do some quick sort of research. And we did all this in collaboration with Wendy Lynch, love Wendy, and Altarum Institute. The first question we wanted to ask ourselves and be able to answer is what the literature suggested, that these things, these unmentionables, you can read them down the left part of the screen, that they're prevalent. And what we saw is that 95% of individuals, and this is statistically significant, demographically representative, not just older, not just sicker, 95% of individuals had at least one of these unmentionables, 40% had between 4 and 6. The next thing we wanted to get at is, yes, but is this a problem real people want solved? Because I think in the healthcare system, we do a lot of, I think it's interesting, so you should think it's interesting. So we invented this notion of the ostrich index, which was a measure of the delta between how much does this thing bother you and how supported do you feel by the healthcare space in it. And you'll notice that the good news is things like diet and exercise has a very low ostrich index because people think it matters, but they think they're getting support. But as you move out towards the right part of that graph, money concerns, bad sex life, relationships, caregiver stress, that delta grows big. And for an audience like this, what I would say to you guys is a delta like that spells opportunity. That means unmet need. We also needed to make sure that this impacted health. And what we saw, also what has been shown in the literature, is that people who had no unmentionables were healthier, and people who had lots of unmentionables were much less healthy. So there was another sort of presence that we came upon as it related to life challenges, which you can think of as coping mechanisms. And we saw that when somebody is going through a life challenge, if they have negative coping factors, in fact, their health is considerably worsened. And these negative coping factors, or magnifiers, specifically were trouble sleeping, being sad or worried, or substance use. We also know people who are very resilient when bad things happened. We called those positive coping factors buffers, and they include strong network of peers, sense of spirituality, and exercise. And what we really wanted to be able to do ultimately was to measure the impact of this thing called life, on our health, on an individual basis and on a population-wide basis. So we came up with this notion called the Vulnerability Index, and it measured the presence and magnitude of life challenges against your own personal balance of positive and negative coping factors. 2 life obstacles that are not included that should be because they're relevant and impactful are sex, bad sex life, and bad work life. But we didn't have customers at that point who were willing to let us go there. So what we did, and you heard about this a little bit last year, was convince some of our biggest partners to let us go live with this and to assess vulnerability and then relate it back to claims. And what we saw was, as you might be expecting, people who are highly vulnerable, when you control for age and gender, are 2.6 times as likely to have diabetes. They are 2.9 times as likely to have back pain. They're 5 times as likely to have mental health issues, and they're costing the system 5 times as much. Now, to be fair, we were not the first ones to come up with this notion. In fact, back in the 80s, there was a study called the ACEs study that looked at adverse childhood experiences and the impact that they have on your health. And what you can see here is it's a foundational negative impact over the course of somebody's life that results in chronic disease and ultimately early death. Matthew, the subject of his Regina Holiday jacket, is actually ACEs, which I didn't realize until he just told me. And you can see him there, a picture with Nadine Burke. Nadine is a world-renowned expert on the impact ACEs can have on risk of cancer and cardiovascular disease, for example. So what is an adverse childhood experience? And for any of you who are out there sitting there thinking, well, I probably wouldn't have any of those, that's for other people, actually the definition is kind of scary. And when you look, it does include some things that we can all hope are not part of our life, but it also includes things like divorce. And we know how prevalent divorce can be. And when you look at the numbers from the original study, 67% of those kids had 1 ACE or more, 12% had 4 or more, and anyone had 4 or more, that was translating to a 2.5 times greater risk of COPD over their lifetime, 4.5 risk of depression, and if you had 7 or more ACEs, 3.5 times the risk of ischemic heart disease, which is the #1 killer in the US. So in the last year, there's been a lot more attention put on this stuff. The Shriver report came out. It covered ACEs and a lot of other studies. If you haven't looked at it, you should. But 2014 also marked the Oregon Medicaid study, which I'm sure some of you are familiar with. I thought this was stunning, and I'm showing off a little bit that I had the opportunity to spend some time talking to Amy Finkelstein. So these are her slides. I think she's a goddess. So what is the Oregon Medicaid experience? Well, experiment. For any of you who don't know, in 2008, Oregon had money to cover some, but not all of those eligible for Medicaid. So they ran a lottery. And that created the opportunity to have a control and an experiment arm, which you can't usually do with a public good because you can't deny it of anybody. So we were able to bring the rigors of randomized trials to this pressing domestic social policy question. So let me ask you guys quickly. Now we've got a control that does not have Medicaid and an experimental that does have Medicaid. What do you think would be some of the impact on that and the metrics that we typically look at, measure? Well, so now I've got a primary care physician when I didn't before. So take something like hospitalizations. Do you think the presence of Medicaid made people go to the hospital more or less? So I would have presumed less. In fact, it was more. So having Medicaid, even though you had a primary care physician, it was more. How about the ER, more or less? It was more. And surprisingly, even though a number of the reasons that people were showing up were non-emergent and things that could have been covered by a primary care physician. How about physical health measures? Are we getting better? Blood pressure, cholesterol. I have Medicaid now. Better? Worse? The same? Actually the same. So what did it impact? Well, this is what is relevant to the topic that we're talking about today, which is what is the definition of health? And the products that we're fielding, what impact are they actually having on people? So the really good news is the presence of Medicaid reduced financial strain by 23%. It reduced the rates of depression by 31%. And it improved self-reported health by 24%. And I don't know about you guys, but when I think about the definition of health, someone's own definition of health, to me, is pretty much it. And I had the occasion to speak to Catherine Baker, who was the other PI, and she said that they fielded a lot of in-person interviews, and they asked people, what did it feel like to have Medicaid? How did it change your life? And what people said overwhelmingly was, it changed everything. It made me feel like I was part of the community. It changed the way that I related to my partner. It changed the way that I related to my children. It made me feel so much less stressed that I could enjoy my life. So as an entrepreneur, the happiest moments are when something that has been seen as outside the mainstream slowly begins to get attention by big brands. So the other beautiful thing that happened in 2014 is what I would argue are three of the biggest brands in healthcare, clearly, but maybe in the country, fielded an extraordinary study on stress. And we're going to bring out those folks to talk about it in a second. But before we do, so it's Robert Wood Johnson, NPR, and Harvard. Before we do, I just want to take a second to acknowledge Susannah, who any of you who've been here for a while remember was here at the very, very beginning and has always been here. Yeah, Susannah! And you've been here from the start.
From the very beginning. From the very beginning, when people didn't know what the Unmentionables was and assumed that it was the sex, drugs, and rock and roll panel, which it pretty much always has been. But then, you know, we also talk about mindfulness and addiction and family stress. And so it really is the 360 degrees of life panel.
Yes, I love that. So while we're bringing out Michael Painter and Kent Bradley, who will be joining Susannah to talk about the results of their stress study, I wanted to remind all of us that the questions we want to be asking today while we're going through this is, what is it that we're actually impacting? And is that solving the problems that real people actually want solved? And are we selling something that real people want to buy? And so let's just throw that out to the audience quickly. Is there anyone here who has some quick data that they can share that would answer this question? Oh, who is that?
I have the data. I can't get up. I'm coming.
So as an explanation, you know, it's not always just the Unmentionables that make a scene. athenaHealth 2.0.
Oh, this is so... Johnathan Bush, look at that.
I have the data.
Yes, this is great. Did you guys remember this moment? Very well done. Thank you, Johnny. So tell us, what is this data that you have?
Well, elsewhere in the environment of healthcare, there are others who are feeling unstable, put upon, sort of generally pressed from the outside, and included in those are doctors. So we've all Dartmouth studied them to death and told them that they're bad because they don't follow some sort of thing that Watson knows what to do on. But as the reality is that an economic model is shifting underneath their feet that they don't understand. And so their humanity is being lost in the process, and 60% of doctors today don't recommend medicine to their children and friends.
Yep.
So that's an example of your very powerful study that doesn't have sex in it, but it should.
Thank you for noticing that. And we'll get back to that. So what about your data? So are we selling something real people want to buy? Let's say, for example, that you reach out to your population and let them know that they have access to, I don't know, Medicare Advantage wellness visit. What do you see as the uptake on that?
Certainly with patients, you see the same thing, where 84%, when we reach out to patients of our clients, and we call them and say, great news, you're entitled to a free Medicare wellness visit. 84% of them say, yes, I know, or now I know, and don't come. They don't want it, whatever it is about it. And if you look at our retail clinic clients, 40% of them have never selected a primary care doctor, even though they have benefits. Among those who have benefits, 40% haven't selected. So if you add it up, it's like 68 million people who could have one say no. They're kind of conscientious objectors to the system that we think is such a privilege that we have to like rally the federal government to pay for. But I was like, yeah, not so much.
Right. It's not offering anything of value. So they know about it, it's free, and they're still saying, I don't want to do it.
Even when they know about it and it's free, the thing that we offer is not the thing that they need, but because we move kind of in study step, where we do a study before we take a step, it's taken a while, and we're finally seeing things here at Health 2.0 that are, hopefully if they don't study it too much and they just start doing it, the experience will be repackaged and people will say, well, that I'll do.
Right, that has value to me.
Yeah.
So I had the great fortune, thank you, to travel with you a lot over the last 6 months and spend a lot of time with providers. It was
enjoyed
fun.
it too.
that didn't, for me, I didn't have a lot of awareness of or really empathy for that part of the world. And one of the things that really hit me is how overwhelming and exhausting the job is, how thankless. And I can't tell you the number of doctors who said to me, privately, they'd pull me aside and say, if so-and-so doesn't care about their diabetes, why should I? So I think the realization for me personally is these unmentionables happen for physicians, for care team members, for nurses, for techs, that these folks are people too. So while you ponder that, I'm just wondering, is there anyone else in the audience who can offer any perspective on whether or not physicians, care team members, that they also might be experiencing these unmentionables?
Does anybody out there have data?
Oh, is that you, Fred? Do you have data?
Yes, I have a little.
This is great. What do you got, Fred?
Okay. So I've made a list of.
Give him the mic. Give him the mic.
I'm forgetting something.
Oh, Trotter.
Impressive. Now I'm ready.
Okay. Give it to us.
Okay. So here's the thing. The first unmentionables for providers are medical errors. We don't talk about medical errors, but we know that all the other unmentionables, the home life, the sleep, the divorce, all the problems that we have, we know that these things from small studies tend to impact. But we really don't have a really good view data-wise on how all of these things impact, with one exception. And the exception is sleep. We have all this data that shows that when doctors don't get enough sleep, residents, they start hurting people. But in 2003, we made some decisions saying, let's give them a little more sleep, and we have not had the expected results. So we expected medical errors in hospitals to go way down, and they didn't. I have a theory why, and it's my second unmentionable. It is the just push through, we did too, let's all burn out together syndrome. So we asked doctors to treat more patients for less money, faster, with greater complexity, and we keep kind of doing a compound interest fashion. It's kind of more and more and more each year. But that's not the problem. The problem is we've created a culture where it's very difficult for physicians to say no to that, right? So this inevitably leads to burnout, and basically this is us failing to scale medicine, and it leads to the third unmentionable that I want to talk about, which is the asshole problem. Some people react to burnout by becoming assholes, and then we tolerate them in the healthcare system, and we have the asshole surgeon who's got the brilliant numbers, and it's amazing, he's doing a really good job. Great in the short term, screwing us in the long term, because when people are made to be afraid and uncertain, they can't solve problems, right? So in general, fear is not compatible with creativity, and doubt cannot give birth to innovation. Which leads me to kind of my own confession, right? Which is, I have had a divorce with a medical student. I failed to make a marriage work because of in part because of her stresses. And here's the thing, I feel comfortable saying that because this is a safe place. The real problem is that we don't have a safe place for doctors to say the same kind of things. And I found this quote, and I have to read it. It says, until the state board and malpractice carriers stop asking the question, have you sought psychiatric treatment? In the same section, that they say, have you been convicted of a felony? And treat a positive answer to either question as the same, physicians will continue to avoid seeking help until they've reached the breaking point. So that's it.
Great.
Yeah.
Thank you.
Thank you.
All right, Fred.
Thank you.
That's good. So I think with that, thank you, gentlemen. For me personally, the Unmentionables has been about helping real people and helping them with these things, like what Fred mentioned about going through divorce and how traumatic that can be. Come on out, Mike Painter and Kent Bradley. Yay! But I do think it's interesting to start thinking about how do we apply these tools to the people who are delivering the care at the same time. So, Mike, I know you've done some amazing work over the last year on the study that you did with NPR and Harvard. Would you please share some of that with us?
I'd be delighted to. Thanks, Alex. Hi, everybody. I get to follow Johnathan and Fred Trotter. That's wonderful. Great. So, as Alex said, I'm Mike Painter, and I work at the Robert Wood Johnson Foundation. Good afternoon, everybody. If you don't know, the Robert Wood Johnson Foundation is the nation's largest philanthropy devoted to improving health and health care. And what we do there is work with leaders like all of you guys across the nation so that we're trying to build a national culture of health. And so what does that mean? Very simply, that means that once we all realize that vision, all of us, everybody, will have the realistic hope and opportunity of living a healthy life. Or everybody will embrace getting healthy and staying healthy as a widespread social value. Just that. I'm a family physician. I'm also a lawyer, among other things. But I'm also a cyclist. I'm pretty much an avid cyclist. And, yay, cyclist. So, I ride my bike whenever I can, even when I'm traveling, like to the Bay Area. I rent a bike. I had a wonderful ride before dinner over in the Los Altos Hills last night. And so I train a lot. I spend a lot of time on my bike. And I was just thinking about training and stress. And it's interesting. When you are training on your bike, you're deliberately, purposefully, and intentionally applying an enormous stress load on your body, and you're doing that for the sole purpose of making yourself stronger, fitter, and faster. In that sense, stress is a real positive. In fact, you cannot get stronger without the stress. But there's also an important sort of flip side to all of that. The more you stress your body, the harder you work, the more miles you put on, the more intensity you sort of try to perform, the more you have to pay attention to that flip side, to the recovery, to the rest, to your social connections, to sleep, to your nutrition, to yoga, to elevating your legs, whatever it takes to really buffer the stress so you can recover and get right back into the training. And if you don't do all that, then you'll burn out, or you'll get injured, or you'll get sick, or all of the above. If you don't manage the stress, then the stress will crush you. So at the Robert Wood Johnson Foundation, we're really, really interested in this connection between stress and health, and we've been thinking about it for a while. In fact, the stresses in our lives, if you think about it, can easily tear down our efforts to build a national culture of health. And in fact, in some ways, the whole reason we have to think about building a culture of health is because instead of a culture of health, we actually have a culture of stress, and it's time to fix that. So, as I said, I'm a family physician. I worked at a community health center in Seattle, Washington for many years, and I came across a story the other day about a patient. Her name is Jeanette, and she's not a patient of mine, but she reminds me of many of the patients I had. She lives in Connecticut, and she was undergoing an enormous amount of stress. She had just delivered a baby. She was about to lose her apartment. She had been fired. And as I mentioned, she's taking care of this newborn infant. So Jeanette was under a tremendous amount of stress. The other important thing, though, was that her child, Shiloh, was also undergoing stress. The people that observed them noticed that Shiloh was not smiling, was not interacting, was despondent. You know, when our bodies are experiencing stress, it does a number of things, our bodies do, including secreting various kinds of hormones like cortisol. And cortisol can be a great thing in a small amount, in the right amount, but with too much and over too long a period of time, it can cause a lot of negative effects, particularly on a developing brain. And it's very likely that that's what Shiloh was experiencing. Over the long haul, stress can cause things or exacerbate things like diabetes, coronary artery disease, depression, things like that. So again, at the foundation, we're really interested in this science of this interaction between stress and health. But we're also really interested in what people are thinking about stress, how their awareness of it, what they're doing about it, how they're managing it. So we collaborated with NPR and Harvard School of Public Health on a public opinion survey about just that, stress. And I wanted to share some of the numbers from that report with you guys today. In the survey, in the results that you can see up here, at least half of the people who responded had some kind of stressful experience during the year, and a large number of those had a health-related experience. So that's pretty interesting. But there's more connection to health. Of those people who were experiencing high stress, most of them, a huge number of them, had an underlying poor health condition, or they were disabled, or they had a chronic illness, something like that. We also wanted to know, well, how is stress impacting the rest of your life? And so the respondents said things like, in large numbers, it's negatively impacting my family life. It's negatively impacting my health, my work life, my social life, and whatnot. We also wanted to know exactly how do they describe stress impacting their health? And in huge numbers, they talked about it affecting things like their emotional well-being, their problems sleeping, their ability to concentrate, things like that. Of those who had a chronic illness or a disability or something like that, over half said it made their symptoms worse, and it also made it harder for them to manage their condition. At work, it made things more difficult. It made it harder to concentrate. It made it harder to take on additional tasks as well. I mentioned at the top about managing training stress, and so we were curious about what are people doing to manage life stress, and a number of people are doing some really interesting things. Things like spending time with their family or friends, meditation, getting outside, eating healthy, things like that. Unfortunately, only half of the people in the survey who reported having stressful experiences were actually managing their stress in any of these ways. Alex mentioned the ELISA Vulnerability Index, and that's another really important window into this connection between stress and health and well-being, as is the public opinion survey that some of which I just walked you through. Both of these are really great pieces of knowledge, but we are still early days in really understanding this connection. I want to leave you with, at the end of the session, we will send out an email to everybody that includes a link to the Burden of Stress Report, the Robert Wood Johnson Foundation, NPR, Harvard School of Public Health Burden of Stress Report. Our communications team also developed an infographic that you can see here that really talks you through how to move from a culture of stress to a culture of health. And we hope you download it, share it, talk about it, use it, put it up on the wall in your office. That's our ask for you right now. Please do that. So we walked through some numbers. The numbers are really, really important. But the stories like Jeanette's and Shiloh's story, which, by the way, they did get help from a program supported by the Robert Wood Johnson Foundation called Child First that goes into homes and helps stabilize families that are experiencing stress like that. So they did get help. But there are many, many other kinds of stories. As it turns out, NPR, when they were developing the programming around the Burden of Stress report, sent out a public call over Facebook asking for stories from the public about stress. And they do this routinely, apparently, like once a week or so. What was important here is they got an overwhelming response. Almost 6,000 people responded with stories about stress in their lives. That turned out to be one of the top 3 responses to those kinds of Facebook calls that NPR has experienced. So stress is really, really important. People are experiencing it and they're talking about it. So that's really important. Again, the goal of the work that we're all doing is health and well-being. But the important thing is we can't realize that goal unless we address stress in our lives. And to do that, that, that means we have to reduce stress where we can, and when we can't, we have to really learn how to manage it. As we're seeing from the index and the report, stress is around us everywhere, and it is making us sick. But here's the important part. It doesn't have to. Thanks a lot. Alex?
Great. Thank you, thank you, thank you. Thank you, my love. Please sit down. So we're going to, Susannah, if you wouldn't mind sharing a couple other of your observations, obviously from your area of expertise. But just very quickly, what I thought was so fascinating about the report that Robert Johnson and NPR and Harvard, I keep saying that because nobody got fired for using IBM. If all of us are out there looking for what do real people want help, what problems do they want help solving? What do real people want to buy? That's opportunity. That's what the healthcare system is striving to do. It's to engage and to get people to want to interact. And I would argue when you begin to see all these big reports coming back to the same conclusions, then you can say that we're triangulating on something. And then the interesting question becomes, how do we solve it? So what do you do? If someone's going through a divorce, if they're caring for an aging parent, how do they get help? Can they get help? And how could we build tools to support that?
And that's exactly what I'm going to talk about today. We've talked a lot about the burden of stress, and what I want to focus on is the good things that can happen when we share. What we see is that in software, we talk about how given enough eyeballs, all bugs are shallow. And you may have also heard an old saying, a problem shared is a problem halved. And there's actually new research that was published this year, a study by Sarah Townsend and her colleagues at USC. And they set up a lab experiment where pairs of undergraduate women were told they were going to have to give a speech. And women who were nervous about it and had the opportunity to share how nervous they felt actually felt better. They gained confidence, and they measured the amount of cortisol in their saliva and found that if they could connect with that peer who was going through the same thing, the levels of cortisol went down. And so the lesson is that if you can connect with someone who's going through the same situation, then you will feel better. And I've seen this in the fieldwork that I've done over the last 14 years. The most important innovation of the connected health era is not access to information, but access to each other. And I've seen it in communities of people living with rare disease, people with life-changing diagnoses, but we also see it among new parents, people who just had a baby, who are able to connect with other people. And we're also seeing it in terms of caregiving, in terms of people who are able to connect to someone like them, who's for the first time setting up their house for an older parent to visit. And what I've been noticing is that there are so many possibilities, so many shared solutions that are actually not spreading. So what the Pew Research Center did is put together census data which shows that we are going to have a huge burden of a sort of pig through a python of the population aging. And we're really becoming a caregiver nation. We are going to have a crisis in the number of people who need to care for our elders. What we find is that 39% of U.S. adults care for a loved one, either an adult or a child, and we are asking so much of these family members. They are taking home people with very medically complex situations. They're being asked to learn how to change diapers, to set up IVs, to manage medications. And they don't just need emotional support, they need practical tips. I met a woman this year who cares for her 6'4" father, and her mother is very petite, and they have a challenge in that they need to turn him in bed to keep him clean and comfortable. And a friend came over one day and said, I know exactly what you need, a baker's spatula. So he went out and bought one and brought it to them and showed them how they could edge it under him and use it as a lever to turn this very large man in bed. And instead of being at risk for back strain and frustration on a daily basis, they are now able to turn him in bed and take care of him. They never would have known that if that friend hadn't come over. He was a just-in-time someone like them, someone who had faced the same challenge of needing to turn a large person in bed. Well, my question is, how could we learn these things? Generations ago, we probably would have learned this from our parents and from our grandparents. We would have lived among the generations who would teach us these things, but that's not the case anymore. It's my idea that the internet can step in. We can start to share these solutions online. We can harness that empathy and the tips that we all have. I really believe the solutions are out there. Another example is that if someone's dealing with dexterity issues, you can stick a pen through a tennis ball or a rolled up washcloth, and they'll be able to write again. Another example, and this is truly an unmentionable, you can actually fashion a hook out of a wire coat hanger and fit it into your toilet so that your demented loved one doesn't flush their adult diaper down the toilet. Now, that's a $500 plumber's bill, and nobody wants to pay that. So my question for this group is, how might we get many eyes on the challenges of home health care? How might we unleash empathy on the healthcare system? And finally, how might we build a culture of health? Thank you.
So next up is Kent Bradley, who you guys had a chance to hear from a little bit briefly before. And I will just say, as an entrepreneur, I think we all need to figure out what problems people want solved, how to sell something people want to buy. But we also need fertile ground to test that. And Johnathan talked before about more disruption, please, and the environment that they're building. I would argue that for me personally, Kent Bradley, I will say this to all of you, sorry, Kent, if you get attacked after this, is a friend to the entrepreneur. And the way that he has approached managing what you can imagine is a large population, he's the chief medical officer of Safeway, and the very different types of stress that people across that organization feel. And the way that you have done it so effectively means that you are figuring the things out that we're talking about on the go. And we can't wait to hear about that. And thank you, by the way, for always being a willing ear to some of the crazier ideas.
Well, thank you, Alex. And I appreciate the opportunity. Loved what I heard as well from both Susannah and Mike. I'd like to share a story. In 2006, I received a phone call. This phone call was from my brother, David. He challenged me to run in the Boston Marathon. Now, you have to realize at that time, I was 44. I'd never run in a marathon. The most I'd ever run was 2 10Ks, and the only reason why I was in some semblance of shape was the fact that I was in the military at the time, and so I had to run a 2-mile run test. But I had more guts than brains, and so I said, okay. And I started running, and it wasn't going well. 2 weeks later, I got another call, this again from my brother, and he told me, hey, Ken, I found out you can't just run in the Boston Marathon, you have to qualify. Duh, I didn't know that. And so I said to him, let's see, I have more guts than brains, but I do have some brains. There's no way I'm going to do this. What's the qualifying time? 3 hours and 30 minutes. There's absolutely no way. And then he reminded me, this wasn't about running a marathon. This was about getting back together with our brother, oldest brother, who was in Boston. And it would be critically important for us to reconcile relationships. For me and my personality, that meant something. That was my purpose. And so I said, okay, I'll give it a try. 19 weeks later, I was with my brother in the Marine Corps Marathon getting ready to start. Now, when that marathon started, I knew exactly why people enjoy marathons. How many people here have run a marathon? It's fantastic. The start of the marathon is like you're running down the aisle, The Price is Right. People are giving you high fives, you're loving life, and things are going great until, of course, you hit that reason why people hate marathons, and that's the 20-mile marker. And at that point, I cramped up, and I slowed down to a crawl, and I didn't qualify. Purpose has a way of driving you forward. And purpose said, find another marathon. And so I did in Miami. And when I went to Miami, I realized there is no good time to do a marathon in Miami. I started the marathon. There was a downpour. I had trench foot by the 13th mile. It was bad. I finished it, but didn't qualify. Purpose wouldn't give up. And it said there's one last chance. There's a marathon in Hartford, and it's all downhill. So I went up to Hartford, I did the marathon, and I was running fast, and it was all downhill. And there was a 3:30 pacer that I just blew by with all the other people going with the pacer, and I felt great until the 24-mile marker, at which time I realized there's a reason why you pace yourself in life. And I ran out of all glucose in my body. I started to think I was going to die, and the pacer passed me as if I was standing still. And it was because I was standing still. I was hurting. But I pushed myself, and I finished the marathon, and with a trembling hand, I looked to see what was my time. And truth be known, it was 3 hours, 29 minutes, 59 seconds. I qualified by 1 second. Now, what in the world does this have to do with the Unmentionables other than a cool story that has a 1-second ending? The fact of the matter is that 6 months later, I received an important call. That call was from Boston. And in that call, it was about my brother Stephen. He was in the intensive care unit dying. And I flew back, and I was able to be with him. You see, I was able to share something with him. On the 16th of April, I was able to share a birthday with him that was followed by the 17th of April and running in the Boston Marathon. Probably one of the most memorable times of my life. And it caused me to reflect what was different about our lives. And I started to think about the time from 2003 until that time in 2009 and realized that our lives had changed. And this is what I'm going to share with you. In 2003, I came back from Iraq. I was a military veteran. I deployed in 2003, came back in 2004. I saw things that you shouldn't have to see. I had a lot of stress. But at the same time, I had a wonderful buffer system. In the concept of the Unmentionables, I had a family that supported me. I had a strong friend that I called my 2 a.m. friend that I could rely on. I had trouble sleeping, but I got back into my sleeping regimen. I was exercising, even though I was forced because I was in the military, but at least I was exercising, and I was doing a lot of things that was really protective of me. So in my way of thinking, I had a lot of fuel in my tank. My brother, on the other hand, had relationship issues. And from those relationship issues, he had work issues. And work was not helping him at all. And at the same time, he continued to spiral in isolation and had all the magnifiers of stress, and his tank was empty. So, when I came to Safeway, I realized that I had this effect, a wham effect to get me going, and that was purpose. And my goal was that work could become a buffer or a magnifier, and I wanted Safeway to have it to be a buffer in our lives. And I think about why this wham effect occurs and what happens afterwards. Now, this is kind of a cheesy, if you will, acronym for how I look at how things are needed in order to activate change. And for me, I thought about the personal aspect and personality. And so when I think about personality, I did some organizational dynamics and personal coaching. I, of course, think about Carl Jung and the way he looks at personality. And so for me, I realized that in order to reach people at where they are at, I needed to reach them from the fact that they are very different persons and their personalities are different. And for me, if you look at it from the perspective of Carl Jung, I don't have time to go all into it, but it's really in this thinking and feeling domain of how we make decisions and this introversion and extroversion. And I clearly fell into this bottom right quadrant where I'm extroverted, but I'm very much into the feeling domain. And for me, purpose, or why, the W of wham, was really important. And that's what grabbed me. But there are others where it's in the H on the left quadrant, and that it's about how it affects other people. And you speak to them by talking about how it affects others. And for other, it might be an A where it's about accuracy and data. And when I talk to physicians, it's definitely that upper left quadrant. And probably a lot of you here are in that left quadrant with the quantified self. And then finally on the right quadrant, it's about me and how it's pertinent to me. We've created several different challenges where we think about how we reach out and communicate change to individuals to activate them. This is an example of one where we begin to think about how we position things. I want to talk about how on a personal level you can imagine how we reach individuals on something as simple as stopping smoking. And as we think about the various programs that Safeway has provided, I think about the value of incentives. Actually, it can activate individuals, or the value of biometric screenings and the quantified self and health education, where people are very much interested in the accuracy, or the fact that our online wellness programs that we have partnered with programs like One Health and our employee resource groups and other things where it's about how you can help other people, and that's how we draw them into those programs. And finally, the fact that for other individuals, it's about a purpose and why this is important that you're involved. Regardless, I believe that getting to where people are at as a personality basis is an important part of the health journey, and why the Unmentionables is important. My final thought is this, as you see this final picture. My final thought is this, that the wham and the activation is important, but the Unmentionables is that tank. And you can ignite an engine, but people wonder about engagement. But if their tank is empty, they're not going to go very far. So we have to build the capacity, and what you all are doing, hopefully, are thinking about ways that we can continue to build the tank of individuals so that when they do get activated, They have the fuel in their tank to be able to sustain the change and really transform into a health journey and get to that place of a culture of health that we need in our organizations and within our country. Thank you.
Come sit and do a quick question for you. Okay, so very quickly, I'm going to pose a question to you guys. We have limited time, but I'd love your responses. So a little bit ago, I had the chance to share the vulnerability index and the unmentionables with a group of executives. And after it was over, a woman who'd been in the meeting came up to me and said, I just want you to know that I almost had to leave that meeting. And so immediately I panic. I'm like, oh, I've insulted them. I did something terrible. And she said, I almost had to leave because I was going to have a breakdown. And I was like, well, tell me what's going on. And she said, my husband is in the final stages of ALS. I'm going to lose him soon. And every single morning I have to get up at 5 o'clock and I take care of him, and then I have to work all day to support us, and then I come home and I care for him, and then I go to sleep. And recently I went to the doctor, and the doctor pointed out that I had gained weight and that my blood pressure had gone off, and had gone up. And the doctor said to me, you know, I think you're really going to have to start exercising. You're not doing so well. You need to work on that. And what she said to me at that moment was, you know, I really couldn't feel worse. And on one level, I was insulted and I was hurt. And on the other level, I was thinking, I don't know what to do. I'm barely keeping myself alive. And your only feedback to me is, you're failing and you should go and start exercising. So let me just ask you guys quickly. Paint an alternative scenario for how a healthcare system could meet someone like that where they are and help them.
Well, I would start by seeing the caregiver for what she really is, someone who's trying really hard and actually doing a good job of holding the household together. And I think there's an opportunity in healthcare to thank people who are doing this public service and to recognize what they're going through. And if you can see someone and show them that you see them, I think that you can then enter into a more positive conversation.
Yeah, I agree that obviously the physician's response was a terrible sort of tin-eared response to somebody who was doing a tremendous amount of work, doing caregiving work, exponentially more caregiving work than the physician was doing in the sort of brief minutes that they were together. There were other things that the physician could have said, which is the physician and the healthcare team could have worked to understand the various stresses that the woman was undergoing, and then acknowledge those stresses. And then, like we were talking about buffers and managing stress, really help her sort of go through and say, what are her assets? What are the resources that she could sort of bring to bear to manage that flip side of the stress that she's experiencing? That seems really important and a real miss.
You know, for me, I think, again, back to my time in the military and how when I was in Iraq, we talked often about this notion of compassion fatigue. And I think about caregivers experiencing that fatigue of compassion. And so, you know, I think there's a time and a place for everything. And it goes back to this notion of filling oneself up. They have to have the energy to move forward. And so first, there's that time of validation that they're doing a tremendous service and that they need that blessing, that feeling that somebody validates who they are as a person. And then there will be a time for that conversation. Maybe you put a little teaser, maybe you follow up, but you got to set your priorities on how you communicate and value and support individuals.
Yeah. Well, and the only thing I'd add is you can't know if you don't ask. So we're doing a really good job treating things that we have decided as an industry matter, and maybe we're forgetting some of the most important factors for someone. For this woman, nothing matters to her on a day-to-day basis more than the fact that she's a caregiver. And you can't know that unless that question's been asked and that hand has been raised. And then there actually are, and there was a panel yesterday here, a number of tools and resources that are beginning to exist that the provider, anyone in the provider care team could then walk this individual, take them by the hand and walk them over to these resources that exist. So thank you guys very, very, very much. Yay. And Vic, if you'll come out here, Suzanne, if you'll stay, you're both allowed to leave. You've done wonderful work. Thank you. So we're next going to talk with Vic about purpose. And I was thinking about something in preparation, which is, I think as you get older, you have all these reflections. And as I'm getting older, I'm noticing that there are a lot of people that I hang out with because I've been in the healthcare space forever who follow this arc. And the arc is that when they get started, they care ferociously about traditional things. You know, I'm going to fix that diabetes. We've got to attack adherence. We're going to solve this problem. And then as time goes on, they evolve. And they evolve maybe because they're heartbroken on some level.